Sorry, good morning, everyone. I'm having slight computer difficulties this morning. I'm not certain whether it's the operator or the computer or possibly both. So good morning, my name's Mark. I'm the Scan for Safety Project Manager here at Leeds Teaching Hospitals and also the Programme Lead in the organisation.
Morning, everyone. My name's Danny Cooper and I'm the Project Assistant in Scan for Safety.
Excellent. So this morning we want to talk you through how Scan for Safety looks at Leeds Teaching Hospitals and how it interacts with GS1 standards and how that allows us to improve patient care.
So just a brief overview of LTHG. We're one of the largest trusts in the country and account for roughly 1% of the Department of Health's budget. And due to changing our focus from cost improvements to waste reduction, we're now one of the most financially sustainable organisations. That's allowing us to reinvest in new equipment each year, and in 2018-2019 that was 66.2 million. We're currently building 2 new state-of-the-art hospitals with £600 million of government funding. And as you can see on the screen, there's plenty of other big numbers, over 18,000 staff, nearly 9,000 babies born. Next slide, please.
Okay, so to look at where we are now, we have a number of core enablers that we put into place. So from the National E-Procurement Strategy published by the Department of Health and Social Care, we built on the Global Standards 1 PEPPOL adoption programme, and we were a demonstrator site and selected as part of that. Our first task in that demonstrator phase was to put 3 enablers in place. These were global location numbers for place, global service relationship numbers for patients, and global trade item numbers for products. From those enablers, we were asked to do 3 things. Could we implement an effective inventory management solution? Could we initiate fast and rapid product recall so that when we have recalls in the NHS, we can find those products quickly and efficiently? And can we implement PEPPOL standards and see some benefits? To be able to do that, we needed several things within the organisation. Our clinical and executive officer support, and we are lucky that we had the Deputy Chief Medical Officer as the Executive Officer for Scan for Safety. He has recently retired and has been replaced by the Medical Director for Unplanned Care and also the Director of Finance as our Executive Board member, both of whom we engage with regularly. We've spent time understanding the standards and how we can combine them to get benefits. And then we've made sure that we've got clinical buy-in. So our clinical colleagues know what we're doing and know what we're trying to do. And that allows us then to reach that golden part of having Scan for Safety at use within the organisation.
So here are the GS1 standards that we use in Leeds. We're able to track our patients using the GSRN, track down to a location using the global location number, and be able to track all our products using the GTINs. And no matter where the patient arrives in the hospital, be that A&E, SAU, elective, or they've just been born, they'll all be issued a wristband with a GSRN. And in terms of deploying GLNs throughout the trust, we have our room and door plaques that are on the left and the bed plaques on the right. We've deployed over 24,000 plaques across the trust, with each room having a door and room plaque, and we're also able to use the GLN extensions to be able to scan down to bed space, diagnostic and treatment space.
So one of the challenges that we identified is that when manufacturers create their own catalogues, we had a problem in that quite often catalogue manufacturers' part numbers were the same. And this was fine whilst we were looking at the catalogue, but the moment we put this into deployment in the organisation, it did mean that people were quoting the wrong codes for the wrong items. We were getting deliveries in and going, this isn't what we expected, and having to send it back. And what we were able to do then is, as part of this, we adopted the use of GTINs across the organisation. So we didn't take any code, we don't apply our own code, we use the GTIN that suppliers and manufacturers use, so we are talking about the exact products. And I've fabricated some GTINs at the end, but as you can see, the GTINs are all different for each item, and that means that when we order something, we're sending you a very clean order out. That enables us to have inventory management at a local level, and we do this in several ways here at Leeds. We have everything from the high-flying RFID cabinets that we use the GTIN to assign to an RFID chip, and we can tell what is in the cabinet at any point, to a basic inventory whereby we use the barcodes you put on the products themselves, either with our inventory staff or by our clinical staff for purposes of issuing, so that we can scan very quickly an item in an operating theatre to count it as used and feed through to our systems so that it's reordered, or also for our materials management team. And our materials management team are a forgotten workforce in this organisation. They provide all the products that are used on our wards and departments. That is 232 locations that have a member of staff that comes onto that area and stocks up all the products that they need. And again, that is barcode-driven data. With our inventory, we have gone paper-free. We do not have a paper order that is left in this organisation. And all our inventory starts with the clinician. The clinicians decide what products they would like available, and we create the computer catalogue. From the computer catalogue, we create the list to create the inventory, and we create the store location. And as you can see here, these are examples of our store locations. We would like to say that we have large, spacious rooms. The reality is that storage within healthcare settings is limited to the broom cupboard, and we end up maximising the tiny space that we have. Once it's in the inventory system, we put the stock levels into the computer. From the computer, our clinicians will pull the item from the shelf. They take it into the theatre, they use it with the patient, and then they scan to say that they have used it. This has actually decreased some of our wastage in the organisation because they can now have a range of products in the operating theatre but know the cost of them. They don't open them until the point that they are needed. This means that anything that's not used can go back on the shelf. Our inventory teams then reorder, and that is sometimes done by a manual push of an order if it's urgent, or by automatic reordering. That goes through the computers again, and the cycle continues. I am hoping for a slide change right about now. So if we look at the benefits of using PEPPOL and using this, first point of call as ever is our clinical teams placing the orders. They count the usage, the system says this is what we need. So whether it is top up and we tell the computer we need X amount, or whether it is the clinical team saying this is what we have used. The computer technology then spits out several pieces of information. One is we send the order through to the general ledger for accounting purposes. The second is that that ledger also then approves the order. They are pre-approved. So we don't have an order that is sat waiting for permission to go out. The stock levels in inventory management automatically transfer the order out as pre-approved. We send out an order that has the exact product location in. We have a global trade item number that we are sending out to you. We know exactly what we want, and it's from your catalogue. We have the exact quantity. So when we need a box of 10, we order 1 box of 10. We do not end up ordering 10 boxes of 10. That information comes through from our catalogue. We pull the matching price through from the catalogue and the price lists. We give you a ship to address. That also comes with a global location number that can be traced back to Location Manager from GS1. So if you want to look in Location Manager, you can look up the global location number, and it will tell you where that goods bay is with its full address and its opening hours and a contact telephone number for that goods bay. We have the exact organisation on there through GLN again, and we will send you out an order number. That comes to yourselves as manufacturers, where you can pick the correct goods, send them to the correct location with the correct quantities. We can receive these correct items. We can match automatically the order number and match the price, and then we can actually automate that payment. This means there are no hold-ups in the payment that is coming through to yourselves. The benefits of this catalogue management and inventory management is that we can see mass data. We can see which products are slow moving, and we can have discussions on wastage. We can see which products are moving quickly and whether we have enough of those on the shelf to cope with demand. This is actually a live snapshot of one of our dashboards, and it shows the product lines that we've actually assigned to a patient in the last 30 days. So we assigned in the period here 10,000 items to patients with a value of £811,000. Of those 10,000 items, 1,100 roughly were implantable items, and we can see the value. We can also see that actually that affected 613 patients. We can see the number of products that we have on the inventory management and the number of locations we hold. There is some skewed data in here. We have a GTIN coverage. We have 86% in our inventory management and 44% in our catalogue. That is not actually as bad as it sounds, because our catalogue does hold items that we would not expect a GTIN for. For example, electricity coming through. Most importantly, when we are recording the batch, lot number and expiry date of the products you send, we can now see this electronically. And this shows us the number of expired products on our shelves, the number of products expiring in the next 30 days and their value, and so on up to 90 days, or the rest of our storage and value. It enables us to manage that inventory, manage the resources for the taxpayer, and make sure we talk to our clinicians when we hit 60 days to say, we've got this product that's about to expire. Is there a patient on your list we can use it for? It also will help you that we can notify you when consignment items are coming due for changing out and being updated. So how does this look for the global position? What are we trying to actually do? This is a complex diagram. It starts with a patient requiring surgery. A clinician sees the patient and decides which implant they require, and they enter it into their appropriate clinical system. That also gets logged into the patient administration system. These feed into two systems. The inventory management system now has a live link to that patient administration system. This means we can track everything back to the patient. We have recently gone live with a new inventory management solution, and we have 100% recording against patients for every procedure. That is an amazing achievement that we are getting that level of compliance. We will also be shortly joining in the theatre scheduling system, and that will provide clinical details of the procedure and the planned date. And we're pulling in all the information you supply in your catalogues. That is the inventory system's role now within the operating theatres to take some of this data forward. We're hoping to get to a point where we can pick and pack, including sizes either side if required by the surgeon. Once the patient is admitted for surgery, all the items can be scanned to the patient and the inventory decreased for what has been used, and unused items can be returned to procurement to be put back on the shelves. If we have procurement putting things back on the shelves, they go in the right place at the right time. All this information can then be fed out, and we are working very currently on some links. So information will transfer out to the electronic health record and that will be able to be seen by the GP and the patient. It means that for the first time, our patients will be able to see which implants are available, have been implanted into them. It will mean that they could have a discussion with their general practitioner about them, and we can gain better knowledge as an industry and as a hospital. It also means that if there is ever that product recall again, we hope to be able to give our patients the first line of defense, which is, I can check my medical records and see what I have implanted in me. Does this concern me? The financial information is transferred out to our general ledger and allows for accounting. We also send information to the hospital costing team so we can ensure that we reduce waste and we see clinical variation decrease. We're working on the links nationally for this data to go into the national implant registries automatically. That will save time and effort in the hospital. And then stock items, most importantly, can be automatically replenished. And the next time a clinician requires that product, we know it will be available on the shelf.
So here's an example of a typical journey a patient may take when in one of our hospitals. Patients often get lost en route or returning to wards, which results in staff having to spend time to locate them. That might be physically going to a ward or phoning round wards. And as you can see, it's quite a complex slide, a fancy slide. So on to the next one, Mark, please. So using the GLNs and the GSRNs, we're able to locate where a patient was at during their treatment. This has inevitably stopped the phone calls, and patients have said that they feel a bit safer as well. More importantly, we've also gained visibility of where the patient was in their theatre treatment, and if a relative was to ask where the patient was or how they were getting on, we'd have better information to go on to advise them. So this is live bed state, and this is basically a collaborative piece of work between Scan for Safety, digital informatics, clinical site managers, and emergency and specialty medicine. We've been able to create a live bed state for the trust that gives us visibility of bed occupancy across all our hospitals, allowing us to plan more efficiently. We're now looking at how we can make this into like an operational demand and occupancy dashboard. All this uses the GLN and GLN extensions as a source of data, and this massively increases patient care and efficiency, and also saves us a bit of money on the bed reporting side. So a couple of examples of Scan for Safety use cases being used in a clinical environment. So we've got blood tracking, which we're currently in the process of setting up the first sites to go onto Blood Track TX. This application uses Scan for Safety and upgrades to our existing systems, which should effectively eliminate wrong blood in tube events from occurring. And it also saves the patients from having two separate venipunctures for cross-matching, resulting in the trust being compliant with MHRA 2 sample rule. The system works off the patient's GSRN to produce a safety check for the nursing staff and acts as a completely safe second check-in system for the nurse. We've also got the intelligent blood fridges, which are basically vending machines for blood. These are located near the high usage wards and stop us from doing any just in case ordering, giving us an accurate inventory of blood that we need at the time, reducing any wastage. We've also got advanced therapies. So Leeds were tasked with designing a solution to track advanced therapy T cells that are taken from a patient and sent to a lab in Edinburgh to be genetically modified. This uses GLN data and provides a complete chain of custody, ensuring that patients get the correct treatment. And this is quite important because it's a very costly procedure. It's in the excess of about 250,000. So next slide. So this slide shows some of the benefits that Scan for Safety brings. So the image on the left shows £126,000 of out-of-date stock that was removed from a RFID cabinet, basically because no one was managing the cabinet. We're now able to manage our inventory and eliminate situations like this from happening. We've also seen a big increase in patient satisfaction due to staff being able to spend more time with the patient by the bedside, delivering a high level of patient care. So patient transfers, this is a clinical benefit we've gained here at Leeds. Instead of making a patient comfortable doing their observations, then going to do all the computer work in the background, we can do all this at the patient bedside using GS1 standards. We update all systems in a simple process to transfer the patient from one ward to another. The result of this is a precise live bed state down to bed level, a record of the patient's journey around the trust, which can be easily accessed on PPM+. And it saves us a lot of time as well. It saves roughly 10 minutes per transfer. And as you can imagine, we're a very big trust, and that's a lot of transfers per year. So currently we're at about 57% of transfers being carried out in this method, but hopefully in the coming months that'll be going up to about 90%. And we've got a short video to play as well, just to give you an example of what that looks like.
Member of the implementation team, and today I will be demonstrating the transfer functionality on PPM Plus mobile app. So the safest way to do this is by clicking on the patient search and scanning your patient's wristband. So that's what we're going to do. So you click into there, click on the QR code that would open up the camera, go to your patient and scan the wristband. This then brings you to the patient's page, and the functionality we're going to use is the update location, which is the icon on the top right-hand corner. So you would click into there. This would open up the camera. You would go to your patient's bed and scan the scan for safety barcode. At this point, you would recognize that that patient is not on your ward, and you would get a pop-up message to say, do you want to transfer the patient to this ward? You would click yes, and that would load up the patient transfer page. As you can see, all the information has already been filled in. You've got your date and your timestamp, the ward that you're sending the patient to, and the bed as well. And the consultants and everyone is all correct. Once you're happy with all the data, you click on the transfer button, which is on the bottom right-hand corner. And this is when it will be speaking to Paz. And once it comes back to the patient's homepage, that means that that transfer has gone through successfully. It would update PAS and the electronic whiteboard. You would then go back to your homepage and sign out.
So that's just one example of how we're using GS1 standards within our hospital to make life better for our patients. And that's very direct. That happens at the bedside, releasing nursing time to care. It's done as part of warding the patient and really makes a difference to the way in which patients feel. Nurses are being taken out from behind a nursing station, removed from being at a computer at the end of the bed to being at the patient bedside. One of the other benefits we've gained is product recall, and here we have a worked example. We received a product recall for some implants at 10:15 in the morning from the MHRA. We then, by 10:28, had confirmed that we did have those products in the trust, but that they weren't going to be used in any of that day's surgery. By 11:42, we had confirmation to the medical director operations that the products had been removed from the clinical areas and that they were under the control of the appropriate inventory managers. That was 136 items that we removed from the organisation very quickly, very efficiently. And it is something that we can do time and time again. It means that we no longer require our clinical staff to be running around whilst trying to carry out surgical lists. We have a team of people that can do it. It also means in the same time that if we had to do a patient recall, we didn't on this, but if there was a patient recall, electronically we could identify those patients, meaning that we are not searching through theatre books that have mass numbers of barcodes in. So I hope you've all found that useful to see how we are using the GS1 standards within our hospitals, and how the information you're providing as suppliers comes through to us and the benefits that it gives to our patients. Thank you for your time.
Thank you very much, Mark and Danny. That was a really insightful presentation. It's absolutely clear of the benefits that the Scan for Safety journey and GS1 standards have enabled across multiple departments at the trust, and also you've made it clear the impact on the patient, and specifically that particular comment around making life better for your patients. It's absolutely crystal clear how you've done that, so thank you. I'm going to hand over to Chris. I think we've got a couple of minutes just to take maybe one or two questions.
Yeah, thanks a lot, guys. Really interesting presentation. Good to see that video and seeing the GS1 standards in action. Just to let everybody know, we've got lots of questions coming in. It's not appropriate to answer all of them right now. Some of them will be leaving for the other sessions because they're more appropriate for the other sessions. But cracking on to the first question, it's specifically for Leeds. How reliable are the barcodes on products for scanning? Is there a way to manually input the code if it will not scan the barcode?
So they're fairly reliable. There are one or two that come through, and the choice of paper usually causes the ink to blur and we can't scan. If we can't scan the barcode, we can look the product up in the inventory system. And actually that's done off a multi-search function. So we don't have to just type in the barcode. We can actually search by what that clinician would know the product has. So we don't risk that error in transposition.
Thank you very much. And another question for you guys. Is there someone in the NHS Trust that can indicate to us how well the Trust are already set up, i.e. percentage of readiness?
I think that's really difficult. Each trust is on a journey and each trust is at a different point. There is no overarching, this trust is at this point. So for example, at Leeds, we are PEPPOL ready, we are running catalogues, we are running inventory. We know that some of our colleagues, they do have inventory systems, but their inventory systems are not as well developed. So it is a case of trying your procurement departments, speaking with your contacts in them, and seeing where that team is up to.
Thanks for that, Mark. Okay, interesting question. I think we'll make this the last question as time is ticking on. Is tracking patients' locations legal?
That's a very interesting question. We track them for their point of their care, and we have to know where our patients are. If you don't know where our patients are, we don't know our bed capacity. If we have a problem, for example, we had a fire in an accident and emergency department, if we don't know where our patients are, we will not know where they are to make sure that we've got everybody out. So yes, it is legal because it is our duty of care to know where those patients are.
Fantastic.